Oh,
Hi, good evening, everybody. Please mute your mics. It's humble request. Welcome to another session of 49th Comprehensive Course on Echocardiography. I'm Dr. Rakesh Gupta, who is going to take up tricuspid regurgitation and pulmonic regurgitations today. Well, as we understood over a period of time, mitral regurgitation and aortic regurgitation can produce significant abnormalities in the heart. Similarly, tricuspid and pulmonic regurgitations, they have significant importance in our heart, basically. Our question will be, how do we analyze them? We look at their anatomy and function of tricuspid valve, etiology of tricuspid regurgitation, which is very, very important as we discussed for mitral and aortic. Then quantification of tricuspid regurg, and last is management issues. The tricuspid valve is a very important structure which has got three leaflets as we have an aortic valve. The most important part is septal, another one is anterior and posterior leaflets. How do we look for septal, anterior, and posterior leaflet is? The commonest view which we utilize in day-to-day practice, starting from apical four-chamber view, parallel long axis view is RV-RA inflow view. RV-RA inflow view will give you anterior and septal leaflet. Parallel short axis view will give you posterior leaflet. This could be septal or anterior. And four-chamber view will give you septal and anterior leaflet. If you look at very carefully, whether it is RV-RA inflow view or focused RV-RA view, the septal leaflet is always there. Anterior leaflet is always there. However, the orientation is a little different. The only question comes, where is the posterior leaflet is? The posterior leaflet is always seen in parasomnic short axis view at aorta. So whenever we ask a question, we always ask this question, where do we see a posterior wall leaflet? And when we say posterior valve leaflet in tricuspid valves, we always see only in parasomnic short axis view at aorta. And why we talk of these leaflets anatomy? Because when we have vegetations, we have to identify which particular cusp of the leaflet is involved, whether it's septal, anterior, or posterior. And these three views, if you remember, whenever we talked of evaluation of pulmonic flow, we always said that evaluation of tricuspid valve, we always said we need to look at all different 5 views. So in looking at tricuspid valve anatomy, remember, posterior wall leaflet is always seen in parasomnic short axis view at aorta. Etiology of tricuspid valve leaflet, it could be primary or secondary. Secondary or functional or physiological TRS. When do we see all these kind of abnormalities? Physiological TRS, when we have no associated abnormalities. What is this? Like you happen to see virtually at physiological TR in every subject what we evaluate in day-to-day practice. In normal scene, in normal subject, without any disease, almost 75 to 80% population is visualized with this abnormality. Look at the leaflet thickness, nothing abnormal, no dilatation of LV and RV, and it's a thin jet just going behind the tricuspid valve for only a centimeter. And the velocity is always less than 2.3 meters per second. Then pathology is, you have to understand the valve morphology, pathophysiological conditions causing TR. Primary TR or secondary or functional TR. Functional TR means a TR which is because of other abnormalities involving the tricuspid valve. And the most common example in our country is rheumatic heart disease with MS-MR, aortic stenosis or regurgitation, leading to secondary involvement of tricuspid valve. In primary, we have whole lot of conditions. Infective endocarditis, congenital heart disease, rheumatic fever, carcinoids, endomyocardial fibrosis, myxomatous, penetrating or non-penetrating traumas, Aortic damage due to cardiac surgery or biopsy or catheter placement, pacemaker implantations. This is very, very important because number of times when we insert a pacemaker, the pacemaker lead get impacted in one of these leaflets and leading to primary TR. Secondary TR is, as I said a few minutes back, secondary to left-sided lesions, pulmonary hypertension, congenital heart disease, and cardiomyopathies. Physiological of TR in mitral valve disease. Look, if we have a rheumatic heart disease, ischemic or dilated cardiomyopathy, they produce MSMR, increased left atrial pressure, pulmonary artery hypertension, RV/RA dilatation. Whenever you increase left atrial pressure, LSI becomes increased, patient may go into left atrial fibrillation. On the contrary, RV/RA, if they get dilated, annulus dilatation happens. And when the annular dilatation happens, it leads to a secondary tricuspid regurgitation. On the contrary, RHD per se involving the tricuspid valve can give rise to TR or tricuspid regurgitation. So in case of a rheumatic heart disease, it could be primary lesion of a tricuspid valve or it could be secondary to left-sided illness. Very old slide, almost 1.5 decade old, talking of the survivability. In people who have undergone a balloon valvotomy post mitral stenosis and look at their survival. Survival is very limited because as we develop a severity of TRS, so is their event for free survival goes down dramatically. So at time, I'm still sure like about 15 to 20 years down the line, whenever we used to deal with the balloon valvotomy for mitral valve, we used to leave the tricuspid annulus as such. And when the paper was published in 2010, if I'm correctly remember, when they said if you leave the TR jet and annular dilatation is more than 40 millimeter or more than 22 millimeter per meter body surface area, these people will often go to a secondary tricuspid regurgitation with poor outcome or mortality morbidity over a period of time. And look at this picture, a very simple picture. What is this? Is it a thrombus or something else in the heart, which is moving in and out? So this is a picture where you can see a thrombus or a moving structure into the right ventricle. Here is LV, LV, LA, RA, RV. This could be a Eustachian valve or a thrombus in migration, or it would be anything else because I'm not able to show and we have to correlate with the history. Second is presence of a large mass in RA, giving rise to almost obliteration of the RA completely. Then another example is valvular endocarditis. Look carefully, it will suddenly come. Here comes a tricuspid valve. Here is a tricuspid valve, which shows evidence of a valvular endocarditis on the tricuspid valve, giving us to significant tricuspid regurgitation. Now we can see it much beautifully, much clearly in the subset. Abstin anomaly, where the tricuspid valve leaflet displacement happens towards the RV apex, more than 7 millimeter per meter body surface area. And look at this plastered septal leaflet. And what is this leaflet is? Anterior or posterior?
Anterior, sir.
Anterior.
A few minutes back, I just saw this interior leaflet. Then atrioventricular canal defect, look, common AV canal defect.
Sir, not audible.
Just a minute, let me get back to. Now you can see a common AV canal defect where we can see this kind of phenomena in this particular patient where we have a significant tricuspid regurgitations. Another important view is like a case of an isolated rheumatic tricuspid regurgitation with pericarditis reported from a journal where they said mitral and tricuspid they were preserved. When we looked at aortic tricuspid valve leaflet, there was significant involvement of isolated tricuspid regurgitation with involvement of tricuspid valve with predominant TR. Carcinoid is a very important condition, which is a neuroendocrine malignancy in which vasoactive substance leads to deposition of carcinoid plaque in the right heart and the chambers. It has a classical appearance of two dimensions echocardiography. The deposition of fibrin tissue on the endocardial surface leads to thickening and retraction of the leaflets and subvalvular apparatus. Over a period of time, the leaflet becomes thick and fixed in the semi-open position, leading to a combination of stenosis as well as regurgitations. I don't have a live picture for tricuspid valve leaflets, but I've got a static pictures of a tricuspid valve leaflet. It's a neuroendocrine tumor, so it will involve not only the tricuspid valve, it will also involve the pulmonic valve also. And look at the thickening of this tricuspid valve leaflet with non-cooptation. And whenever the non-cooptation happens, you have a significant tricuspid regurgitation. Important thing is look at this Doppler flow pattern. Sharp acceleration, slow deceleration. Normally, we do not have a sharp acceleration and a slow deceleration. This is a triangular shape pattern involving TR jet velocity, suggesting that the severity of TR is much more, which is depicted over here. Look at the scale. It appears to be 3 meters per second, but the severity of this TR is much more than 3 meters per second. Endomyocardial fibrosis in another condition. And this is very classical. I could pick out this picture from one of my armamentarium. Look at this myxomatous tricuspid valve leaflet. This patient had a replacement of aortic as well as mitral valve leaflet. And somehow this tricuspid valve leaflet, which is myxomatous along with core triatum dexter, was left behind during surgery. And again producing a significant tricuspid regurgitation. Iatrogenic, as I said a couple of minutes back, pacemaker lead implantation leading to significant tricuspid regurgitations. Then comes secondary to the left-sided lesions, and I'm sure all of you have seen this. Here is a patient with mitral stenosis who had his mitral balloon valvotomy done long back, presenting with evidence of significant tricuspid regurgitation. So it's secondary. So what we need to do is we have fixed up this mitral valve, but at the same time we should fix up this tricuspid valve so that the TR does not improve significantly. This is a patient which we delineated from one of our work in Paolo University. When we see double chambered right ventricle, and how do we see a double chambered right ventricle is? Look at very carefully. This is aorta in the center. This is LA, this is RA. Here is a tricuspid valve. Here is a proximal RVOT, and here is a distal RVOT. And you look at a band kind of a thing seen over here. This is double chambered right ventricular. And if you switch on the colors in this, we will find an evidence of significant tricuspid regurgitation. First of all, not tricuspid regurgitation is seen in another view, but we see now we can see a gradient across this particular band. And apart from the gradient across this particular band, we have a significant tricuspid regurgitation originating from tricuspid valve. And this tricuspid regurgitation originating from this particular valve has got a significant gradient. You can measure the velocity of this gradient is almost 4.5 meters per second or 5 meters per second. If this is the cutoff, is almost 4.5 meters per second. So double chamber right ventricle presenting with severe tricuspid regurgitation. Now, this is a case of a dilated cardiomyopathy, 4-chamber dilatation, LV, LA, RA, RV, and here's a moderator band. And this is a secondary conditions where all 4 chambers gets dilated, producing a significant amount of a tricuspid regurgitation. Here is example for ARVC, arrhythmogenic right ventricular cardiomyopathy. Almost the apex is being obliterated by a lot of fibromuscular bands. We have a significant tricuspid regurgitation. And on top of that, the most important part of this tricuspid regurgitation, the gradient is less than 3 meters per second or 2.5 meters per second. Diagnosis is suspected by echocardiography, but proven by a cardiac MRI. So if I have to say on a functional basis, as we said in the mitral stenosis, the same thing would be applicable for mitral regurgitation. The same thing would be applicable for tricuspid. Normal leaflet motion, annular dilatation, or perforation type 1. Excessive leaflet motion, prolapse versus flail, is type 2. And restricted leaflet motion is type 3, where thickening or fusion or dilatation of LV and LA. Now let me go back and ask you what kind of abnormality this is. Anybody will open their mic and let me know. What is this abnormality? In which class do you classify this myxomatous degeneration? Anybody would like to take a vote?
Flail leaflet, sir.
Pardon?
Flail leaflet.
No. Classification
Flail.
of tricuspid regurgitation. Which category? Grade 1, 2, 3, 1A, 1B, 2A, 2B, 3A, 3B. So this is myxomatous. Look at this hypermobile tricuspid valve leaflet. And if you go back to my original classification, which I showed you a few minutes back, this is a flail leaflet or a prolapse leaflet. It's a type 2 of a tricuspid regurgitation. Why I'm asking all these kind of a thing? Suppose I've got annular dilatation because of the concentrated lesions, or I've got a perforation. Perforation needs valve replacement. Annular dilatation needs annuloplasty or trick valve. If you have a prolapse or flail leaflet, we have to deal it accordingly. If you have a thickening and fusion of tricuspid valve, possibly due to what? Rheumatic process, it needs an settlement-like replacement. LV-LA dilatation leading to a dilatation that's needs trick valve or annuloplasty. So if you happen to understand the pathophysiology, that is a treatment of this subset of population. Now comes quantification. Take my words, if you have a good transthoracic echocardiography, this is the most important thing in evaluation of the tricuspid valve leaflet. But the most important thing is, what is a primary, secondary, or physiological TR is? We have to understand that phenomena very well. So what are the factors which we utilize for assessment of tricuspid regurgitation jetters? We look at a color flow mapping, vena contracta, flow convergence, pulse wave, and a continuous wave Doppler. Same thing, nothing significant, nothing new about it. And in the last, I like to show you what is the most important thing amongst all these kind of things. Color flow mapping, detection of large eccentric jet which swirls around is considered to be severe. Small thin central jet are considered to be mild. Now look at this large jet which is swirling around. This is large jet which is swirling around, and this is what is known as Honda effect. So what will happen if you happen to see this subset of population? Here the regurgitation jet is coming like this and going back as a positive signals of red color. The large eccentric jet which swirls around are considered to be significant. And then comes vena contracta. In tricuspid valve regurgitation, we should spend a lot of time on vena contracta. Unfortunately, this vena contracta is not seen in Plaque's window. This vena contracta is seen in apical four-chamber view. And here is like a vena contracta. We just hold on this image. Let me hold this image for you because you should understand how to calculate the vena contracta. So what we do is we look at a vena contracta, and once we look at a vena contracta, I'm trying to hold this image for you. Yeah. So what I'm going to do is I'm going to hold this image in mid-systole. And then look, you measure the difference from this point to this point. The blue color or the gap between the two leaflets through which the jet is originating. Something like what we did in mitral or aortic regurgitations. Importance is vena contracta width as a predictor for adverse outcome in patients with severe TR. Look, it's a very classical paper published in JACE 2011, talking of the vena contracta with less than 7 versus more than 7. So, and this is what's follow up over a period of time. First is cardiovascular death, and second is overall death. Almost ratio remains the same. If the vena contracta is less than 7, we have a better outcome than vena contracta more than 7 millimeters of size. Then, over a period of time, initially till 2014, we talked about mild, moderate, and severe tricuspid regurgitation based on this vena contracta. But a paper which was published in 2017 by Gemerano et al., it categorically said we have to improve this vena contracta to less than 3, less than 7, less than 14, less than 21, and more than 21. So less than 3 is mild, 7 is moderate, 14 is severe, less than 21 is massive, and more than 21 is torrential. Any one of you can get up and ask me, what is the outcome of this mild, moderate, severe, massive, and torrential? Well, the question is, as we develop a bigger vena contracta, as I showed in my previous slide, the outcome of these people are pretty poor if we don't take care of them at an appropriate time. And I'm not going to talk you about at this level, how do you calculate effective regurgitant orifice area or vena contracta evaluation area by 3 dimensions echo. At your level, if I happen to see a tricuspid regurgitation, if I go and measure only my TR jet vena contracta, less than 3, 3 to 4, 7, 7 to 14, 14 to 21, and more than 21, we are comfortable enough to talk about this kind of phenomenon. This slide very carefully. This is stage 1, stage 2, stage 3, stage 4, stage 5. What is the utilization of these kind of? Stage 1 is mild, no symptom, TR less than 2 plus, normal RV function, no remodeling, no treatment. TR is 3 plus, normal RV function, mild remodeling, none or low dose diuretics. Wake symptoms, severe TR, mild RV dysfunction, diuretics. Previous right heart failure episode, severe TR, moderate RV dysfunction, moderately high dose of diuretics. And here is complete RV dysfunction with high dose of diuretics. So, if you have to ask this question is, I say mild, moderate, severe, massive or torrential. That's what you need to remember in your clinical practice. Then next important aspect comes in this subset of population is, if I've got a tricuspid regurgitation, what will happen to my forward flow velocity? First, when I started with, I said the first point is anatomy of the tricuspid valve. Second, I said the cause of the tricuspid regurgitation. Third, I said the vena contracta. Fourth point is pulse wave Doppler spectrum across tricuspid valve. The positive forward flow velocity, if I've got a severe tricuspid regurgitation, it'll go up. On the contrary, what will happen to the posterior side? Like as we look at a pulmonic veins in mitral regurgitation, what will happen to my hepatic venous structures? So forward flow will increase and reverse flow will definitely go down, as seen in this particular slide is. We have a systolic and diastolic forward flow in the sense the hepatic vein always drain into IVC. And that's correct. Whenever we have a significant tricuspid regurgitation, the word will reflect to, it will reflect to first truncation of the systolic forward flow, and then reversal of the systolic forward flow into the hepatic veins. Look at this. This is a forward flow which is happening from hepatic vein to IVC, and there's a reversal of flow in this diastole during one of the cycles of the TR jet velocities. Same thing, we can put a cursor across this tricuspid valve leaflet M mode, and then we can see what exactly happening at tricuspid valve. I'm trying to show you like what is the hepatic venous flow. Now look at this hepatic venous flow is almost forward hepatic venous flow. It's all blue in color because it's away from the transducer. And if I put a cursor across this line and do an M mode, what I'm going to get is, this is beginning of a systole and diastole. Look, it's all red through and through. Same patients, if you happen to see a significant tricuspid regurgitation, look, this is a forward flow. And there's a reversal of, this is a forward flow or in continuous wave, we have a dense TR signal with full envelope suggesting of a severe TR. And pulmonary pressure would be significantly elevated if we have a significant tricuspid regurgitation jet. What is the consequences of tricuspid regurgitations? RV gets dilated IVC with reversal of flow in hepatic veins, hepatic congestion, and pulsatile flow in RVC and SVC. This is what I was saying in the beginning. If you have to assess a TR jet, you have to assess TR jet in 5 different windows. Plaques window, we do not see anything. We go to RV, inflow view. So what is this leaflet is? What is this leaflet is?
Anterior and septal.
Anterior and septal.
This is one is septum. You forget so easily. And here, see, this is what? This is what?
Posterior.
The posterior and
anterior or
posterior.
septal.
Okay. Septum and
Anterior
here
near
is
the
anterior.
aortic wall and posterior at the lateral side.
All right. So what we finally says is, if you have to look for a tricuspid valve, I'll go back to my previous first presentation is, first is assessment of a tricuspid regurgitation by color flow mapping. Second is vena contractor. Third is PISA. Fourth is pulse wave Doppler, and then a continuous wave Doppler. Color flow mapping, as I said, we have a significant tricuspid regurgitations. Then second is vena contracta, more than 7 is considered as severe. Third is flow convergence. We look for a PISA. I'm not going to talk of PISA at your level at this particular moment. Then fourth is a pulse wave Doppler, integrate velocity and a hepatic venous flow. And I was trying to show you this hepatic venous flow, but I'm not really comfortable with my own images because here I could see a systolic reversal. Here is a systolic flow is present and here's a reversal in diastolic flow. So I'll have to go back and look why I'm looking at this kind of a thing over here. So it's correct. What exactly this slide is showing you, I was not comfortable when I was talking about this slide is, look, this is all red in color. So what exactly means by? So blood is going back from IVC to hepatic veins. That is systolic reversal. Here is blue in color. Here is classical diastolic blue in color. It means the blood is flowing back from a hepatic vein to IVC. Now you can understand very categorically. And this is what is important issue. As we have a reversal of flow in pulmonic vein in mitral regurgitation, we have a reversal flow in hepatic veins in tricuspid regurgitations. Finally, continuous wave Doppler, dense signal of TR jet velocity and raised pulmonary artery pressure are significant of tricuspid regurgitations. 5 windows. What we look is parasternal short axis RV inflow view, then parasternal short axis view at aorta, then 4-chamber view, then focused RV view, and lastly the subcostal window. Classification, I told you already, mild, moderate, severe, massive, and torrential. 3D area construction could be a possible feature, but I'm not going to talk you on this right now. And in conclusion, we can say that tricuspid regurgitation is dependent on first physiological TR, less than 1 centimeter square behind the tricuspid valve leaflets, velocity less than 2.75 meters. Then comes primary tricuspid regurgitation or secondary tricuspid regurgitation. And we have to look what is the cause of this TR jet so that we can deal them accordingly. Third important thing is evaluation. Evaluation is the most prominent thing is identification of leaflets, which is causing all these kind of problems. Evaluate them, but the most important thing at your level is the vena contracta. And second important thing would be forward flow velocity with reversal of flow in hepatic veins. Now comes management issues. This is my own thought process. Look, let's go back to my first slide, talking of the causes of tricuspid regurgitations. Now the question comes, if I've got a type 1, where the leaflet motion is normal, but we have a significant tricuspidation, how do we manage? If you have an annular dilatation, you do annuloplasty. Annular dilatation means more than 40 millimeter of a size of the tricuspid annulus. And if you have a perforation, you replace the valve. So you have annular dilatation, tricuspid annuloplasty, and perforation, replace the valve. Replacing the valve over here is important because we do not replace with high profile valve, we replace with low profile bioprosthetic valve because the gradient between RV and RA, they are very small. It's very rare to see a prosthetic valve, metallic prosthetic valve in RV position. Majority of time is a bioprosthetic valve in RV position. Then second is prolapse and flail. If you have a prolapse and flail, again the same issue comes. We try to put this flail in prolapse valve leaflet by doing annuloplasty, or some people, they try to replace it. And the word is going on around the world that we can do a clipping of these valves, which are flayed on the right hand side as we do a mitral clips on the left hand side. Last is restricted mobility, thickening and fusion. Obviously, these valves, this relationship, secondary to left-sided pathology needs valve replacement. LV dilatation needs finally a annuloplasty. Now, let me show you what important things are happening in this word apart from the valve replacement. I said you do annuloplasty or you replace the valve whenever you have a severe tricuspid regurgitation secondary to left-sided lesions. But the most important thing is when we are not able to replace these valves in these sick patients, what we do? We do a trick valve, like putting a valve with the valve inside the SVC as well as the IVC. And how do they look like? It's like a valve where is the blood will only come from SVC to RA, IVC to RA, but there will be no regurgitation of flow of this trick valve, this kind of a valve, which is seen over here and implanted in SVC and IVC. And here's another valve which is put in this patient is what? This is a core valve. This is a bioprosthetic, no, not bioprosthetic. These are TAVR valves which are implanted percutaneously into the aortic valve positions. And what is this? This is mostly appears to be clips of mitral clips, and here is mostly a pacemaker which is implanted in the subset of operation. I'll stop over here. Take your questions on tricuspid regurgitation. One by one, you can mute and like send a request. I'll just pick up and see what you are wanted to know about this particular position of tricuspid valve leaf. And the first question has come from Sachi Surendran. Go ahead.
Sir, good evening, sir.
Good evening.
I am not able to understand the hepatic venous flow and the color mapping related to it, sir.
Okay, I'll go back again. You ask me as many times as possible. I'll be happy to answer this question because what to talk of you, even I took a lot of time to understand this kind of a phenomenon. Let's go back and let's look at the slide again. And I'm not going to come out till you say that I'm satisfied. Okay?
Okay.
Can you see my slides now?
Yes, sir.
So here is hepatic vein. IVC. Here is hepatic vein. Here is RA.
Yes,
If
sir.
in my color, so what exactly look it's happening in this patient? I'll hold this image for you. Now I'll bring this cursor back to beginning. So during this is systole, this is diastole, right?
Yes,
So
sir.
concentrate over here in systole. I'm going to take this cursor during systole. There is only blue color which is coming from hepatic vein to IVC.
Yes, sir.
Correct?
Yes, sir.
Play now. So what is it saying that whether is systole or diastole, there's a flow of blood from hepatic vein to IVC. Is that correct?
Yes, sir.
Now let's move to the next film. The same patients now, I say this cursor line into the hepatic vein and trying to do the M mode. What's my mode is saying? This is my M mode over here. And this, what's is telling me? This is all red in color and this is slight blue in color. Red in color, slight blue in color. Red in color, slight blue in color. This is respiratory variations are happening. So whenever we'll have an inspiration, what will happen? A lot of blood will go inside the lung, RVRA. So
Yes,
TR
sir.
velocity will reduce to a large extent.
Yes, sir.
So normally this should be blue. This should be blue. This should be blue. This is all should be blue. But we have seen there's a reversal of flow, like blood is going back not from a IVC, hepatic vein to IVC, but is going back from IVC to hepatic veins.
Okay.
Whenever a significant tricuspid regurgitation will happen, it will help in reverting the flow in hepatic veins from IVC. Are we clear now?
So that is red. The reversal is red.
So blood reversal of flow will happen, correct? Now look at this, all blue in color.
So explain again the last part.
The reversal is red color, sir.
Now let's go back to the fundamentals. This is hepatic vein, this is IVC, correct?
Yes. Yes, sir.
During systole or diastole, the blood will flow from hepatic vein to IVC.
Yes,
So
sir.
whether it's systole or diastole, it'll only be a blue color because blue is away.
Blue is away. Yes, sir.
So all time this should be blue in color. Go back to this picture.
Blue.
It'll be all blue all the time, systole or
Yes,
diastole. Correct.
yes, sir.
If
Yes,
I
sir.
put my cursor across it and happen to see a red color during systole, what does it mean by?
Okay, sir.
That is going from
There is a
I
reverse.
to hepatic veins.
Yes, sir.
Correct?
Yes, sir. Yes.
So
Okay, sir.
whenever we have a
Okay,
significant
sir.
tricuspid regurgitation, the reversal of flow will happen with systole.
Yes, sir. Okay, sir.
Correct?
Yes, sir.
Remember, this is very important phenomena, and this is phenomena, same phenomena is used for constrictive pericarditis. But in constrictive pericarditis, the flow reversal happen only in the first beat of expiration. Here,
First beat after expiration.
first beat of expiration. If I'm taking a deep breath inside and I gave a breath out, as soon as I gave a breath out, the first beat will tell me if there's a reversal of flow, that is hepatic venous flow reversal in constrictive pericarditis. But here, there's no constriction. You see a reversal of flow in all systole, 1, 2,
Yes.
and 4. They could be little variable because of respiratory process, but they are seen virtually in all subjects, all leads.
Okay, sir.
Clear?
Yes, sir.
Okay,
So this signifies severity of TR, sir.
correct. Next person. Everybody will become smart with this. Oh, great. Tricuspid is not really a big rocket science, but tricuspid is a big nuisance value. Because majority of these people they'll come back with congestive cardiac failures. And we have no option. Like touchwood, we have a tric valve now. It's very expensive. We have a tric valve, but at one time we had a lot of problem what to do with these kind of patients. And these patients, when they had a mitral valve replaced and the tricuspid valve is left behind, their life is very shortened down. And unfortunately, when these valves were replaced, subsequently, they had a poor outcomes. Dr. Mahatre.
Yes, sir. Sir, explain again the RA, RV inflow in tricuspid regurgitation and all positions of the leaflets again, please. Basic positions of the leaflets.
Position of leaflet.
In all 4-chamber RA, RV inflow and short axis.
Okay. So first position of these leaflets. Remember, basal short axis view is the only view where we see a posterior leaflets. First, basal short axis view at aorta. And if you happen to look the anterior leaflet, we see anterior leaflet on this apical 4-chamber view, septum and anterior, and RV are in flu anterior and septum. That's the first question you asked me. Second question is the 5 windows of the tricuspid valve leaflet, where we evaluate the pathophysiology of tricuspid valve. Where do we evaluate the pathophysiology of tricuspid valve? We have 5 windows. These 5 windows are, we do not see anything in plaques window. So we go to passive short axis view at aorta, RVR in flow view, then passive short axis view at aorta, then 4-chamber view, and then focused RVRA view. Look at this is focused, like LV, LA, they become sideline, and we are focusing on RVRA, and finally the subcostal window for evaluation of a tricuspid jet severity. Anything else, Dr. Matre?
No, sir.
All right.
Sir, last time I had asked, I'm not able to get the aorta and the suprasternal view. I tried many times.
Yeah, you asked me this question. I don't know like how to show you how to get this aorta and the suprasternal window.
I tried with the neck extension, still I'm not able to get those views.
Your aorta, look at my chest, I think I'll be able to give you an answer looking at my, stop sharing this. If this is my left hand side, this is my aorta. The aorta arises from here, goes up like this, up, and then bends posteriorly. Correct? So what we do is we should keep a pointer in this suprasonal window towards this side, and slightly the angulation should be on this side way. Here should be ascending aorta. 1 o'clock pointer and ascending aorta over here. Same pointer, if you pointer remains the same, but this is facing first to the right hand side, and then same thing is facing towards left hand side. I'll get a descending aorta. Do this when you go back.
Okay, footprint only
1 o'clock,
changes.
slightly towards right hand side, ascending aorta, slightly towards left hand side is descending aorta. Because they're not in the same plane. They go up, turn around, goes posteriorly down. So they'll not even find them same position, same angulations. There'll be two different angulations.
I'll try again.
Okay. Dr. Ravi Bala Mahajan. Dr. Ravi Bala, are you there?
Good evening, sir.
Good evening. Go ahead, Doctor.
Sir, hepatic venous physiology again, sir.
Hepatic venous physiology.
Little bit slower, sir.
Okay. As you wish. You will see, I'll do that. Now, this is a slide which talk of a diastole and systole.
Yes, sir.
Normally, what happens? This is hepatic vein. This is IVC.
Yes, sir. Yes, sir.
You see, diastole, the blood is showing blue in color, and systole, the blood is showing red in color.
Yes, sir.
It means during diastole, the blood is coming from hepatic vein to IVC.
Yes, sir.
In systole, the blood is going from IVC to hepatic veins.
Yes, sir.
When does systole happen? When tricuspid regurgitation give rise to systolic reversal of flow or diastolic reversal of flow?
Systolic reversal of flow.
Correct. So in systole, whenever the severe tricuspid regurgitation happen, instead of blood coming from hepatic vein to IVC, the blood goes from IVC to hepatic veins.
Yes, sir.
Clear?
Yes, sir.
Now let me go to this particular. This is M mode. M mode across,
Yes.
you put a line across this and take an M mode. So
Yes,
this
sir.
is systole, this is red in color.
Yes, sir.
So this part of red in color means the blood is coming systole. Blood is not coming from hepatic vein to IVC. Blood is going from IVC to hepatic vein.
Yes, sir.
But during diastole, you see a blood is blue in color.
Blue in color.
The blood is coming from hepatic vein to IVC.
Yes, sir.
Systolic reversal by color flow mapping M mode.
Yes, sir.
All right. Now you go to the slide. What will happen during this hepatic venous flow in pulse wave Doppler? Suppose you kept a pulse wave Doppler over here.
Yes,
So you
sir.
find a wave over here, which is systolic wave, but then diastolic wave,
Yes, sir.
right? This
Yes, sir.
systolic wave is not seen. In fact, you see a positive wave in this
Yes, sir.
during systole. It means positive wave means the blood is going back IVC to hepatic.
Towards. Yes, sir.
Is that clear now?
Yes, sir.
Oh, I believe my words, nothing wrong about it. Even I took a long time to understand it. And
Thank you, sir.
I'm preparing a talk just on hepatic venous flow. In which circumstances this hepatic venous flow happens and how does it happen?
Yes, sir. Sir, can you show constructive pericarditis M mode?
Constrictive pericarditis M mode. Why not? I can show you right now over here. It'll be good. Give me a second. I'm just trying to find out my slide. I need a 1 second minute.
Yes, sir.
All right. I got the slides. Just give me a second. It is 94. So let me share this slide presentation with you. Now look at my slides.
Yes, sir.
So whether is systole or diastole, the flow is
Yes, sir.
happening in the hepatic vein to IVC.
Yes, sir.
Correct. Now, this is respiratogram. This is inspiration.
Yes, sir.
This is expiration.
Expiration.
The first beat after expiration, first beat after expiration, you see a reversal of flow.
Yes, sir.
In inspiration, you can jolly well say, look, in expiration, you are showing me a reversal of flow. But in inspiration, look, this all system
Yes, sir.
hepatic vein to IVC drainage. And this
Yes,
is
sir.
M mode, which is seen in expiration. In our case, this expiratory flow will not be variable. This will be all be systolic truncation, not only in first phase of expiration. It will be all completely in all phases of the respiratory movements. Whether inspiration or expiration, it will be a reversal of flow in systolic reversal of flow.
Yes, sir. Thank you, sir.
Thank you. Dr. Janvi Javan.
So in constructive pericarditis, there is a diastolic reversal, sir. Is it like that after expiration?
Okay.
Is it a diastolic?
You have to understand the pathophysiology of constrictive pericarditis. My heart is enclosed in a shell of calcium. Correct. Now, normally what happens, if I take a deep inspiration, the RV-RA flow will increase. Correct?
Negative.
In
Yes, sir.
expiration, my RV-RA flow will reduce.
In expiration.
In expiration. Correct?
Yes.
But heart is expendable in normal circumstances. But in constrictive pericarditis, heart is not expendable. Whatever the volume of the blood in LV and RV remains the same.
Yes.
So what happens? During inspiration, the interventricular septum will bulge towards LV to get more blood inside.
Yes.
When expiration happens, there's nothing like expansion. The expiration happens, the interventricular septum, instead of bulging toward left-hand side, start bulging towards right-hand side. And when this happens, you have a TR, the blood will reverse back into hepatic vein because IVC is plethoric. There is a stoppage at the level of IVC.
Yes, sir.
Yes.
So as soon as you expire, the first beat in expiration, whether it's systole or diastole, we're not talking of that. The reversal of flow happens in both the circumstances.
Okay.
Diastole and two.
Correct.
Thank you.
We do not call that a systole diastole. We say reversal of flow in the first beat of expiration.
First beat of expiration.
Expiration is important in that.
First beat, I showed you the slides.
First beat.
Of expiration.
First beat.
First beat.
Correct. Dr. Neeraj Dodke.
Good evening, sir. Sir, can you please explain the normal hepatic venous Doppler waveform?
Very simple. Let me just go back and show you the normal hepatic venous Doppler waveform. Give me a second because I have to take out this presentation again. Echo is a very interesting phenomenon. Believe my word, I don't know how many of you will really pick it up, how many will disappear over a period of time. But it's a very interesting phenomenon. One of my senior always call these words WHY syndrome. Why this is happening? That's all he'll say. And he said, put your head together to say why. Why is happening? And this why will give you so many answers. And it's true that why gives me so many answers number of times. It's not that one time. It'll give me an answer in number of times that why syndrome will give me an answer. You can see my slides now?
Yes.
Yes, sir.
Now, I'm going to freeze this image for you. And look at the cursor. Cursor is right over here. So I'm going to scroll back this cursor for all of you. Now, this is beginning of a systole. So what do you see? A beginning of systole. All blue in color. Now, the blue color is a coming hepatic vein to IVC. So what it'll do? It'll produce a forward flow from hepatic vein to IVC. Right?
Yes.
So what you'll find? You'll find only a forward flow.
So what do we mean by forward flow in the waveform? Will it be below the baseline?
Below the baseline. Like, let me go to the next picture. Forward flow would be here. You see, like you'll find a wave over here, another wave over here. Okay.
So, sir, systolic wave would be larger than the diastolic wave?
Correct. Let me just stop sharing. I'll give me a second. Let me find out another picture for you. Heart failure. Light.
अब ला दो ना प्लेट। आप लोग का हो गया? हाँ तो दे दो, है ना? और जिसने भी खा लिया उसका चल रहा है।
P1. Can you see my slide now? Is it
Yes.
clear? Okay. So what we do is, this is hepatic vein, this is IVC, this is hepatic vein. We'll put a sample volume right into the hepatic vein over here. And what we do the sample volume in hepatic vein is, look, this is beginning of QRS complex to next QRS complex. So this is systolic forward flow. Forward flow means the blood is draining from hepatic vein to IVC. If I keep my sample volume over here, what will happen? The blood would be negatively seen, systole and diastole.
Okay.
Clear? And this is what is more important in hepatic vein to see systole and diastole. During the cardiac cycle, all flow would be in the same direction.
Okay.
So
Then what is that SR and DR?
don't look at that because it'll get confusing. This is, suppose you've got significant tricuspid regurgitation. So blood, instead of coming from hepatic vein to IVC, will have either truncation or reduced or reversal of flow.
Okay.
Okay.
Yes. So we will be learning this in another chapter.
Hepatic vein, we'll see again during constructive pericarditis.
Okay. Okay. Thank you.
Dr. Janvi.
I have two questions, sir. One is, what is the mechanism of that repair surgery? What you are told that springs are kept in IVC, SVC. How it acts mechanism?
Those are not
Mechanism.
spring, Janvi. Those are.
Repair surgery, whatever.
Yeah, this is a newer modality of a treatment for tricuspid regurgitation is, if you look at this image very carefully, this is SVC, this is IVC. So this is a valve which is self-expandable valve which is implanted in SVC.
There's a spring like
Yeah, it's a mesh. It's not spring-like. It's a mesh.
Mesh.
So it will only help us in coming the blood from IVC to RA. Reversal of flow will not be seen in this.
Yeah.
Similarly, the same thing is put in IVC. This is SVC, this is IVC. The blood will come from IVC to RA, but the reverse flow will not be seen.
Yes.
Like one side flow of blood. Look, the same thing is implanted over here. This is a valve which is implanted into SVC and IVC positions. Here is TAVR valve, transaortic valve replacement in aortic stenosis.
Okay.
Here is Marta clips. Here is a pacemaker.
Okay.
So this
One more question, sir.
Go ahead. Yeah, ask me.
Sir, actually, it is not related to this topic. Today, I had an echo of a patient admitted with AMI. He was in shock. He was having inferior wall plus true posterior wall infarction. But when I go to round it, he was having a cold extremities, but BP was showing 110 like that. Patient was having some hypoxic thoda behavior. He was anxious and irrelevant talk. So, but when we are done, I was thinking there is RV infarct, but when echo was
RV
done,
infarct or IV infarct? RV
it
infarct.
was a RCA in right coronary causing posterior wall and inferior septum infarct on echo. ECG also showing that, but patient was in shock. So
Why the
we
you
were
mean to say
expecting
why the patient
we
is
were
in shock?
expecting there should be RV infarction and therefore patient has gone shock.
Correct.
But echo was not showing RV dilated, but IVC was dilated. But RV was not dilated and it was okay for contraction.
Janvi, look, for whatever you said, how do I interpret that patient is? That patient has got a dominant RCA with the posterior descending artery arising from RCA. That's why he or she has got involvement of the posterior inferior wall. And feature for RV infarction is not dilatation. The feature of infarction is poor RV systolic contraction, which is seen by TAPSE, RV free wall TDI, or RV two-dimension strain. And as far as I'm concerned, as you said, IVC was dilated. I'm pretty sure that patient has got RV infarction. If you go back tomorrow, put a pulse wave Doppler spectrum pattern at M mode at tricuspid, you will find TAPSE. Two dimensions TDI at RV free wall, it will be reduced. RV is not the answer.
Okay. So RV dilatation should be expected. It should be poor contractility by doing this TAPSE and
TAPSE, RV free wall TDI, and if you have this RV strain by looking at the RV strain of all three segments of RV.
So clinically, he was in shock, and that is because of LV. LV was not so much, it was maybe 40% ejection fraction, what we were able to calculate. But patient was in shock. Probably I was thinking RV, but I was expecting the RV dilate hota hai, but that should not
RV dilatation will not be there. There will be a reduced RV systolic. When you'll see RV dilatation is when you have a primary pathology of the RV, like patient presenting with pulmonary embolisms.
Yeah. Yes. Acute corpal. Okay, sir. Thank you, sir.
Anybody else would like to ask this question? Lalit, Dr. Bhardwaj. Go ahead, Dr. Lalit. I've seen you for the first time asking some question. I'm really happy.
Second time actually, sir.
Okay.
And my question is, sir, that measurement of vena contracta, can you explain in mid systole when we are measuring the vena contracta, how it is different from the measurement of cusp separation and the vena contracta?
Cusp separation is two-dimension finding. Vena contracta
Ideally, they should be. Is there any difference? Technically, is
the
there any?
difference is there. They may not be of a cusp separation. Because I'll give you an example. I belong to a village, Like in our village time, when we were living over there, there used to be a door of woods. And during the time of winter, when the wind used to blow, what happened? The air used to come inside from between those doors. Correct?
Correct, sir.
So, despite there was no gap in between, potential gap in between, the air used to flow. But
Yes, sir.
over a period of time, those doors, you look at me, those doors, they become slightly bent up. So now there's a potential gap between those two doors.
Yes.
So that gap through which the blood is arising, whether the doors are whether bent or not bent, this is a gap between these two leaflets through which this blood is arising. I said, what is this? This is flow convergence, vena contracta, and then dissipation of flow. So what we measure vena contracta is during systole. Look, this cursor is red in color. During systole, the amount of this opening which you see between the two leaflets, so-called potential two leaflets, it may be there, may not be there, which is known as vena contracta. So go to mid-systole, see how much is the biggest inside. That's why, over a period of time, we have started working not on two dimensions. Now, if you really ask me the severity of a tricuspid regurgitation, I'll go to my three-chamber view and put a cursor across with, yeah. Now, this is a volume acquisition. Here is a vena contracta. So what I'll do, I'll go to this line across this cursor and bring it to my side. And when I'll bring it to my side, I'll be seeing whole of this vena contracta through which it's happening. Look, this is anterior tricuspid leaflet, posterior tricuspid leaflet, septal leaflet. Then I'll trace this complete septum to get a real vena contracta. And this will be area, that'll be volume. Here what you are doing is, you are just measuring this part over here. Look carefully, you are only measuring this part.
Yes.
So at your level is comfortable. I'm not saying, but true vena contracta would be something like this. Here the true vena contracta is something like this. So at your level, just remember this, the severity of tricuspid regurgitation based on vena contracta, dimension echo. I'm not saying 3 dimensions echo. Today, if I have to really make a diagnosis for MR also, so I'll put a tube inside and look at a 3 dimensions vena contracta. Dr. Fabulous was talking of 2 dimensions vena contracta, correct? And she said one sentence, possibly you remember or not, if you happen to see multiple jets of a mitral regurgitations, so it will not be evaluated. No, if you happen to see a multiple jet, why you're seeing a multiple jet is because the tricuspid valve mitral valve has got 3 cusps. So you'll find a gap between A1 and P1, A2 and P2, A3 and P3. Same thing, if you take an like 3 dimensions echo, you take an, like suppose MR is happening over here. You take an 3 dimensions echo and picture and bring this image towards you. Look, in front of you, the blood is coming towards you. So you can see a
Yes.
potential gap in rounded structure or in sickle shape format. And then we calculate the area in that. And that area is taken anything more than 0.4 centimeters considered severe. At your level, this is what you should remember. I can't tell you more than this because it will become more confusing.
Already confusion started.
Okay.
Thank you.
Thank you, sir.
Dr. Mahananda Matre.
Yes, sir. Sir, RV free wall TDI, where we should put that on the RV free wall, anywhere we can put the cursor? How we should measure? Tab
Here.
se we know it.
Here. At the RV free wall annulus.
Can you show on the image, sir?
Give me a second. Free wall TDI. So I have to go to pulmonic evaluations. So give me a second. Let me go to pulmonic evaluation. Okay. 150. Just a second. Give me a second and are you able to see my slides?
Yes, sir.
Tap say across the RV3 wall, we have just put a line across this RV3 wall to measure the systolic anterior motion. Tricuspid annulus plane systolic excursion. Same thing if I put my sample volume at the RV free wall, pulse wave sample volume at RV free wall. In this short axis view or in apical 4-chamber view, you put a sample volume at this point, what you get is a systolic forward flow. Systolic contraction of RV free wall. Clear?
Yes, sir. Sir, एक gentle suggestion करना था. I think all will agree with me. Actually, your teaching and physiology and showing images is excellent, and we understood the lectures very well.
Yes, sir.
कि 2-3 lectures ऐसे हुए थे जहाँ पे आपने नहीं लिए थे. It
Yes,
lot
sir.
difference actually. So
Lot of-
फील ही नहीं आता है सर.
हाँ,
फील ही नहीं आता है.
अगर possible है तो आप ज्यादा से ज्यादा lecture लेने की कोशिश करना.
Please, sir.
Okay. I'll try to do
You are
this.
a hardcore teacher, sir.
Yes, sir.
Hardcore
All
teacher.
will agree with me, I think.
सर 2 लेक्चर से मॉरल इतना डाउन है ना कि बात पूछिए मत.
Don't reduce your moral because look, believe my words. When I came to US in 1991, I sold off everything at my place to have my fellowship in cardiology. And everybody can't do that. I left my kids behind. My wife, she was doing a gynae fellowship. My son was taken care by my mom. And I wanted to learn a lot many things because at that time, nobody was teaching echocardiography in India. And this is one modality which makes a lot of difference in your clinical practice. And if your moral will go down, what will happen is people will start leaving completely. And the best answer is just send me anything which you feel is you do not want to disclose to somebody. Send on my personal WhatsApp message. So look, this is
Yes,
what.
sir.
So it will not discourage other faculty member also. At the same time, it will help me in not reducing your moral values.
Yes, sir.
Yes, sir.
Thank you, sir.
Thank you, sir. Thank you so much.
So with this, I've stopped sharing. Dr. Sachi, you have some more questions before I'll take a 5 minutes break and take your PR also, because that's recording. I have to do it separately. We'll go back to the link and join again. And Dr. Sachi, any questions from your side?
Yes, sir. The TAPC and TDI, tissue Doppler imaging at the free wall of RV, does they have any correlation, sir? And why does that TDI comes in the positive side of the spectrum, sir?
Okay.
When actually the annulus is supposed to go away from the probe.
I'll come back to the slide. That'll be a better option. I'll stop sharing this and go back to my pulmonic again. Now, Sachi, look at this slide very carefully. You can see the slides, right? Can you see the slides, Sachi?
Yes, sir.
Yes, sir. दिख रहा है, sir. अच्छा दिख
Right. So if I put my cursor over here, I'm looking at the forward contraction. My apex is fixed. My base moves toward the apex. So this annulus will move towards an apex to give you a forward contraction of this annulus movement. Here is the forward contraction of the annulus movement. Right. His second question is, when this is not negative, this is positive. This is apex, this is annulus. So this same annulus is moving up towards the apex. So you get a positive S wave. This is E prime and A prime wave of the tricuspid annulus. This is S wave of the tricuspid annulus. So again, it will be positive. Clear? I hope you understand what I'm saying is.
A prime and E prime, why it is going down?
This is E prime, this is A prime.
It is. Yes.
Why they going down? Because if the contraction is happening towards the apex, the relaxation will happen away the apex.
Yes. Yeah, prime.
So that's
yes.
why we get E prime and A prime.
Okay.
And amongst this TAPSE and RV free wall, TAPSE is more consistent, more dependable than RV free wall TDI. Remember this thing very carefully. And if you happen to look at this patient very carefully, look, basal part is contracting. Apical part is possibly hypokinetic.
That we could not make out.
So this is what is measured by two-dimensional strain. So what we,
Ah.
instead of looking at all in one go, we look at apical, mid and basal RV free wall. In pulmonic embolism, what will happen? Apical sparing happens. So apex would be spared, mid and basal would be hypostatic. In type 3 LAD lesion, apex would be involved, mid and basal would be spared. In chronic obstructive lung disease, all three would be reduced.
Okay.
So in emergency, during our COVID time, I was able to say that, look, this patient has got a pulmonic embolism. You remember that McConnell sign?
Sir, once again, please repeat what happened in what this trade pattern.
If apical sparing is present, which is McConnell sign is there in pulmonary embolism, so apex would be spared, mid and basal segments would be involved.
Okay.
If type 3 LAD, wraparound LAD, apex would be involved along with LAD territory, mid apex would be involved in reverse to sparing, and mid and basal segments would be preserved. Chronic obstructive lung diseases, all three segments would be involved.
Yes. Yes. Thank you.
Right.
Thank you, sir. Thank you.
Thank you. Dr. Tanay?
Good evening, sir.
Tanay Sajan, go ahead.
Sir, should we measure TAPSE in every patient where we see right ventricular dilatation?
Tanay, in my practice, I always measure my TAPSE whether I see a dilatation or not. Because in my routine echocardiography, this is the only point which tells me about RV systolic function.
Sir, in every echo patient, we should measure TAPSE and RV free wall TTI.
Every echo patient. And this recently has given more importance in stress echo also. Post-stress echo TDI TAPSE is measured to assess post-systolic contraction of the RV free wall.
Thank you, sir.
Okay. Any other questions before we take a 5 minutes break? If you allow me, let me just pick up a tea and coffee. It's around, what's the timing over here? I'm still in California. I'll be flying today, and it's about 9 o'clock in the morning here in Yorba Linda in Los Angeles. So give me a break for 5 minutes. We'll join again.
Yes.
We'll talk of a pulmonic regurgitation.
Okay.
And meanwhile, you can have a break. I can't tell you to have your dinner at 5 minutes time, but you can spend some time with your family for next 5 minutes. I'm sorry I'm taking on Saturday because on Friday I was traveling from this place in Tennessee. That was place was named Chattanooga. From Chattanooga, I was flying to this part of California yesterday morning. So I couldn't take your class on Friday morning. So Friday evening at your point. So give me just 5 minute break. I'll pick up a cup of tea, and then I'll rejoin again from the same link. Okay?
Okay.
Thank you.
Thank you.